Patient is admitted to the emergency department with a new onset chest pain that is radiating to their left arm. It came on shortly after performing a 5 km run. The patient has a past history of angina. You perform an ECG and note the following. Sounds like MI. ST depression leads V1 to V3. Tall R waves in leads V1 to V3. Inverted T waves in lead AVR. All other T waves are normally oriented. What is the most likely diagnosis? ST depression leads V1 to V3. Is this anterior and STEMI? Then there's tall R waves in V1 to V3. Why are there tall R waves? QRS, tall R waves. Inverted T wave in lead AVR. Where is AVR? AVR is pointing to your right arm. Oh, is it pointing to your left arm? Right arm. AVR is pointing the right arm. What does inverted T waves in this direction mean? It would be a bit too simple if it's anterior and STEMI. There must be a reason they are talking about the tall R waves and T waves. So I'm going to guess posterior STEMI. Because this can be reciprocal changes. Yes, the answer is posterior and posterior STEMI. A posterior MI causes ST depression, not elevation, on a 12-lead ECG. This patient has most likely experienced a posterior STEMI. On a 12-lead ECG, ST elevation would not be noticeable, and so only reciprocal changes are visible in leads V1 to V3. The changes associated with these leads include ST depression, tall broad R waves, upright T waves. Upright T waves in V1 to V3. Okay. Unstable angina might cause ST depression due to ischemia, but the pattern on the ECG is characteristic of a posterior STEMI. So next time when you suspect an anterior non-STEMI, check the T waves, check the R wave. Is it tall and broad? Is the R wave tall? And check the T wave in AVR as well, huh? Okay. Inverted T waves in AVR are normal and are nothing to worry about. An anterior STEMI would present with obvious ST elevation in leads V1 to V3 or V4. Reciprocal changes would be seen in the inferior leads. And STEMI usually causes abnormal inverted T waves. An aortic dissection classically presents with tearing chest pain radiating to the right. Okay. Next question. You're on the phone with a 56-year-old gentleman who is concerned about his blood pressure control. He has been monitoring his blood pressure at home on a daily basis over the past week. His reading has been consistently over 140/90. with the highest reading being 154/86. He's otherwise well in himself with no chest symptoms. He has a past medical history of hypertension and is currently taking perindopril, an ACE inhibitor, who is previously on amlodipine, but this was stopped as he developed significant ankle edema whilst taking his medication. His recent blood test shows the following: sodium on the lower end of normal, potassium normal, bicarbonate normal, urea normal, and creatinine is normal. Which of the following is the most appropriate next step management for his hypertension? So what do you add after ACE inhibitor? And he already tried calcium channel blockers, but it has caused him significant ankle edema. The other one that he has not tried yet, in that first 3 things that you should try, is a thiazide-like diuretic. Is there any contraindications? None that I notice. Let's try thiazide. Yes. So thiazide-like diuretic is the correct answer. Poorly controlled hypertension, already taking ACE inhibitor, add a calcium channel blocker or a thiazide-like diuretic. Yep. Nothing much to explain here. Next question. A 34-year-old man from Eswatini presents to the emergency department with a 3-day history of fever. Where's Eswatini? Shortness of breath and dry cough. His past medical history includes tuberculosis and HIV, and his most recent CD4 count is 150. Is that good or bad? Need to find out later. On examination, heart rate 100 per minute, blood pressure 110/80, respiratory rate 28, his tachypnic, oxygen saturation 98, air at rest, that's okay. Dropping to 80 on walking, that's not good, and it's quite typical of something, PCV. Pneumocystis gyrovecii. His temperature is 38.5 degrees Celsius. On auscultation, his chest is clear. How would you treat this man? How do you treat pneumocystis? It is not a reactivation of TB. How do you treat pneumocystis? RIPE is the treatment for tuberculosis, but it is not describing tuberculosis. Although he did have a history of it, and there is a chance of reactivation. I'm not sure how to treat pneumocystis gyrovecii. Cefotaxime, ciprofloxacin, tazocin. Tazocin is a very broad spectrum antibiotic, so maybe not. Cotrimazole, cotrimoxazole. Let me guess this thing. Wait, doesn't it have to be IV? Let me guess this then. No, my first guess was correct. So the answer is oral cotrimazole. Pneumocystis gyrovecii pneumonia is treated with cotrimoxazole, which is a mix of trimethoprim and sulfamethoxazole. Okay. The man has pneumocystis gyrovecii pneumonia, PCP, which occurs in HIV-positive patients with a low CD4 count. It classically presents with a fever, dyspnea, dry cough, exercise-induced desaturation, and very few chest signs. It's treated with oral cotrimoxazole or IV pentamidine in severe cases. Okay. So oral treatment is enough, and the treatment of choice is cotrimoxazole. Severe cases, IV pentamidine. Okay, next question. John is a 67-year-old man with hepatocellular carcinoma, currently admitted to a hospice for end-of-life care. He is complaining of nausea without vomiting and would like something to help relieve this. Nausea without vomiting? Like something to relieve this. He has hepatocellular carcinoma, so he's under palliative care, I think. On examination, he appears jaundiced and there is a large amount of ascites present. He's feeling bloated and has not opened his bowels in 2 days, but is passing wind. Which of the following medications would be most suited to treat his nausea? Which of the following medications would be most suited to treat his nausea? He has not opened his bowels in 2 days, but is passing wind, so there is no obstruction. But not passing bowel for 2 days. Is he on any medications? Morphine doesn't treat nausea. What treats nausea here are ondansetron, metoclopramide. Metoclopramide treats nausea, vomiting, cyclizine, and haloperidol. So among these four, which one is the most suitable? If it's related to him not opening bowels, he might need a laxative with his antiemetic. I don't know how to go about this question. Ondansetron, metoclopramide, cyclizine, haloperidol. Let me just try ondansetron and learn from mistakes. The answer is metoclopramide. Why? So D2 receptor antagonists should be used in palliative care for nausea and vomiting. That is due to gastric dysmotility and stasis. Okay, so metoclopramide promotes peristalsis, right? So that's a reason why they are presenting this information to you, not pass bowels for 2 days. So they want you to kill 2 birds with 1 stone. And what they're saying here is probably the nausea is due to the gastric dysmotility and stasis. So you're going to treat that, and that will help with the nausea. Okay. The choice of an antiemetic in palliative care setting is dependent on the cause of nausea. The symptoms John is experiencing is suggestive of gastric stasis. In this situation, a prokinetic drug such as metoclopramide D2 antagonist will help ease his symptoms. Movement-related nausea can be treated with cyclizine, which prevents the vomiting center from receiving signals from the vestibular apparatus in the middle ear. So cyclizine is for movement-related nausea. Haloperidol should be used to treat metabolic causes of nausea. According to NICE guidelines, where's the mention of ondansetron then? What's ondansetron used for? According to NICE guidelines, a benzodiazepine can sometimes be used to treat sickness due to anxiety. An example of a situation where it may be appropriate would be before chemotherapy. Morphine is used in palliative care to treat pain. It can induce nausea. Any mention of cetrons? There's some notes on this. Worth going through. So palliative care prescribing nausea and vomiting. Nausea and vomiting in palliative care is often multifactorial. However, it's still important to identify the most prominent cause in order to guide choice of antiemetic therapy. 6 potential syndromes have been identified in palliative care, with gastric stasis and chemical disturbance being the most common and prominent. 6 broad nausea and vomiting syndromes. Reduced gastric motility may be opioid related to serotonin 5-HT4 and dopamine D2 receptors. Chemically mediated, related to hypercalcemia, opioids, or chemotherapy. Visceral or serosal. So if chemically mediated, just now we discussed that we would use haloperidol. Is that it? Metabolic causes. Visceral or serosal causes of nausea and vomiting due to constipation, oral candidiasis. Raised intracranial pressure, usually in the context of cerebral mets. Vestibular, related to activation of acetylcholine and histamine 1 receptors. Most frequently in palliative care is opioid related. Can be motion related or due to base of skull tumors. So opioid causes of vestibular nausea, huh? Interesting. Cortical nausea and vomiting may be due to anxiety, pain, fear, or anticipatory nausea related to GABA and histamine 1 receptors in the cerebral cortex. In palliative care, pharmacological therapy is usually the first-line method for treating nausea and vomiting. In general, there are 2 approaches to choosing drug therapy, either empirical or mechanistic. An empirical approach involves choosing medication based on either physician preference or commonly a dopamine antagonist. For example, metoclopramide is used first line. Alternatively, the mechanistic approach utilizes matching choice of antiemetic drug to the likely cause of the patient's nausea and vomiting. So ideally, we like to use the mechanistic approach. So let's learn the mechanistic approach. So reduce gastric motility, you want to give a prokinetic agents, as they are useful in these scenarios as the nausea and vomiting is usually resulting from gastric dysmotility and stasis. According to NICE-CKS and BMJ best practice, first-line medications include metoclopramide and domperidone. These are D2 antagonists. However, NICE-CKS indicate that metoclopramide should not be used when prokinase may negatively affect the gastrointestinal tract, particularly in complete bowel obstruction, gastrointestinal perforation, or immediately following gastric surgery. Okay, because you're gonna might cause a rupture in these cases. Chemically mediated. If possible, the chemical disturbance should be corrected first. In the context of other chemically mediated syndromes, for example due to opioid medications, there are a number of suggested medications. Key treatment options include ondansetron, haloperidol, and levomepromazine. Chemical mediated. Okay, ondansetron and haloperidol are used for chemically mediated. Opioid medications cause chemically mediated one, not vestibular ones. Visceral or serosal causes can give cyclizine and levomepromazine. First line, anticholinergics such as hyoscine can be useful. Raise intracranial pressure. NICE-CKS guidelines recommends using cyclizine for nausea and vomiting due to intracranial disease. Dexamethasone can also be used. Radiotherapy can be considered if there is slightly raised intracranial pressure due to cranial tumors. radiotherapy. Vestibular. NCKS and BMJ best practice recommends use of cyclizine as a first-line treatment in disorders due to the vestibular system. So a lot of them, cyclizine is actually first line. Visceral cyclizine first line. ICP race cyclizine first line. Can use dexamethasone as well. Vestibular cause cyclizine first line again. Refractory vestibular causes of nausea and vomiting can be treated alternatively with metoclopramide or prochlorperazine. Atypical antipsychotics such as olanzapine or risperidone can be used in refractory cases according to UpToDate. Cortical. If anticipatory nausea is the clear cause, a short-acting benzodiazepine such as lorazepam can be useful. If benzodiazepines are not ideal, BMJ best practice recommends use of cyclizine. Ondansetron and metoclopramide can also be trialed. This is quite common sense. If they are vomiting, don't give orally because they'll just vomit it out. Okay, next question. A 69-year-old attended his GP complaining of easy bruising, loss of appetite, and weight loss that has worsened over the last 6 months. This doesn't look very good. On examination, he has extensive non-tender lymphadenopathy affecting cervical and axillary nodes and hepatosplenomegaly. Suspecting hematological malignancy, his GP sends for an urgent full blood count and peripheral blood smear. The results suggest a likely diagnosis of chronic lymphocytic leukemia. Which of the following cell types was most likely seen on the patient's blood film? What is seen in chronic lymphocytic leukemia? Smudge cells, Reed-Sternberg cells, Wheeler formation. I don't remember all these keywords anymore. Power rods, pseudo, Pelger, wet. Not heard of this. I'm gonna just guess smudge cells. That's the correct answer. Probably. Okay. So the correct answer is smudge cells or smear cells, also called smudge cells, are a characteristic blood film finding of CLL. Smudge or smear cells are cell remnants that arise during the slide preparation and are the result of abnormally fragile lymphocytes in CLL. Reed-Sternberg cells are associated with Hodgkin's lymphoma. Let's have a look at how each of these looks. Smudge cell. So this is how a smudge cell looks like. Because of the large lymphocytes, fragile lymphocytes. When you put them on a slide, you smudge them on the slide. So they are called smudge cells. Next one, we're looking at Reed-Sternberg cells and Hodgkin's lymphoma. So Reed-Sternberg cells look like owls. You have owl eyes. These are Reed-Sternberg cells of Hodgkin's lymphoma. Wheeler formation is associated with multiple myeloma. Wheelers. Rollers. So they are like red blood cells lining up to each other. Is there a reasoning behind this happening in multiple myeloma though? The stacking of cells facilitates the rate of red cell sedimentation. Can be caused by poor preparation. Conditions that can cause Wheeler formation include infections, multiple myeloma, Waldenstrom's macroglobulinemia, inflammatory and connective tissue disorders. So you have kinetics of linear roller formation according to this person. Smoshowski aggregation of the kinetics of colloids is based on the assumption that each particle is surrounded by a sphere influence. As aggregation proceeds, the average diffusion constant of the aggregate population decreases. This doesn't explain anything for multiple myeloma, I think. Rolio. High levels of monoclonal immunoglobulins in patients with myeloma cause the red cells in peripheral blood smears to stick to one another in a linear fashion. Okay, then. It's because of the high immunoglobulins. That's something to do with Brownian motions, as we read just now. Then. Alright. Our rods are a feature of acute myeloid leukemia. How do our rods look like? Our rods, they are like rods inside the cells. Okay. I saw Wikipedia here. During acute myeloid leukemia, acute promyelocytic leukemia, and high-grade myelodysplastic syndromes and myeloproliferative disorders. Although our rods are named, they were first described. Why do they happen in acute myeloid leukemia? Our rods in blast support diagnosis of acute myeloid leukemia. They don't say how it's formed. No, nothing about how it's formed. I guess something you just have to commit to memory then. Up to date. Please give me something useful. Let's go to the first one first. Our rods. White blood cell disorders. The precise disease classification may rely upon evaluation of abnormal circulating cells, for example, the presence of our rods in blood. No. Nope. Rod-like conglomeration of granules in the cytoplasm. Oh, so it's actually made of granules. It's actually made of granules in the cytoplasm. Okay. And last one, this is seen in CML, pseudo-Pelger wet cells. Let's just copy this and search. Pseudo-Pelger wet CML. Okay. Chronic lymphocytic leukemia features and investigations. Actually, I'm not very good in differentiating between the 4 different types of leukemia. I need to study on these. So CLL is caused by monoclonal proliferation of well-differentiated lymphocytes, which are almost always B cells. It is the most common form of leukemia seen in adults. Okay. Features, often none, may be picked up by an incidental finding of lymphocytosis, constitutional symptoms, anorexia, and weight loss, bleeding, infections, lymphadenopathy more marked than chronic myeloid leukemia. Investigations, full blood count, lymphocytosis, anemia, blood film smudged cells, also called smear cells. Immunophenotyping is the key investigation. Is that all? So we know that it's more common in adults. One of the most common leukemia seen in adults, and most of the time is B cells. Usually no symptoms, and then you can find it incidentally or through constitutional symptoms like weight loss and anorexia. Okay. Next question. Oh, do you have nice videos here? Chronic leukemia. I guess it's worth going through because Osmosis has quite good videos. Let's do this.
Learning medicine is hard work. Plan with exclusive video. Try free today. Luke refers to white blood cells. With chronic leukemia, Luke refers to white blood cells, and emia refers to the blood. So in chronic leukemia, there are lots of partially developed white blood cells in the blood over a long period of time. These partially developed white blood cells interfere with the development and function of healthy white blood cells, platelets, and red blood cells. Now, every blood cell starts its life in the bone marrow as a hematopoietic stem cell. Hematopoietic stem cells are multipotent, meaning that they can give rise to both myeloid or lymphoid blood cells. If a hematopoietic stem cell develops into a myeloid cell, it'll mature into an erythrocyte, or a red blood cell, a thrombocyte, or a platelet, or a leukocyte, or a white blood cell, like a monocyte or granulocyte. Granulocytes are cells with tiny granules inside them, and they include neutrophils, basophils, and eosinophils. If a hematopoietic stem cell develops into a lymphoid cell, on the other hand, it'll mature into some other kind of leukocyte, like a T cell, a B cell, or a natural killer cell, which are referred to as lymphocytes. Once the various blood cells form, they leave the bone marrow and travel around in the blood or settle down in tissues and organs like the lymph nodes and spleen. A chromosomal abnormality in hematopoietic stem cells that are destined to become leukocytes is the most common cause of chronic leukemia. Some examples of abnormalities include a chromosomal deletion, where part of a chromosome is missing, a trisomy, where there's one extra chromosome, and a translocation, where 2 chromosomes break and swap parts with each other. Now, there are 2 types of chronic leukemia. The first is chronic myeloid leukemia, or CML, which is caused by a particular chromosomal translocation that affects granulocytes. The second is chronic lymphocytic leukemia, or CLL, which is caused by a variety of chromosomal mutations that affect lymphocytes, in particular B cells. Both CML and CLL cause cells to mature only partially, and that's a key distinction from acute leukemias, where the cells don't mature at all. As a result, these abnormal, premature leukocytes don't work effectively, which weakens the immune system. In addition, the chromosomal changes alter the cell's normal cell cycle. As a result, in CML, the cells start to divide way too quickly, and in CLL, the cells don't die when they should. And in both situations, we're left with way too many of these premature cells. So over time, premature leukocytes accumulate in the bone marrow, until eventually they spill out into the blood. Now, some of these guys settle down in organs and tissues across the body, but others keep circulating in the blood. With a bunch of extra cells in the blood, all the healthy cells get crowded out, and it's tough for them to survive with the extra competition for nutrients. This causes cytopenias, or a reduction in the number of healthy blood cells, like anemia, which is a reduction of healthy red blood cells, thrombocytopenia, or a reduction of healthy platelets, and leukopenia, or a reduction in healthy leukocytes. In chronic myeloid leukemia, the most common cause is a chromosome translocation, which results in a Philadelphia chromosome. And that's where a portion of chromosome 9's long arm switches with a portion of chromosome 22's long arm, and we write that as T922. T because it's a translocation, and 9 and 22 because those are the chromosomes that switch genetic information. This results in a modified chromosome 9 and a modified chromosome 22, and it's the chromosome 22 that's called the Philadelphia chromosome. So in the Philadelphia chromosome, a chromosome 22 gene, which is the BCR gene, ends up sitting right next to a chromosome 9 gene, the ABL gene. When they're combined, it forms a fusion gene called BCR-ABL, which codes for a protein also called BCR-ABL, which is a constitutively active tyrosine kinase, meaning that BCR-ABL is like an on-off switch stuck in the on position. Since BCR-ABL helps control various cellular functions like cell division, having it always on forces myeloid cells to keep dividing quicker than they should, which causes a buildup of premature leukocytes in the bone marrow that eventually spill into the blood. The premature leukocytes then move to the liver and spleen, causing swelling of those organs or hepatosplenomegaly. And because these CML cells divide quicker than they should, there's a high chance that further genetic mutations can happen. And if that happens, CML might progress and accelerate into a more serious acute leukemia, which is called a blast crisis, because the totally immature cells of acute leukemias are referred to as blasts. A lot of cases of these blast crises include the formation of a trisomia in chromosome number 8, or the doubling of the Philadelphia chromosome. In chronic lymphocytic leukemia, the most likely cause is also a mutation in the cell's chromosomes. We just don't know which particular mutation, or mutations. Whatever the case, the result is that B cells start to interfere with the pathways of B cell receptors, which should only be signaled during infection to activate a few specific tyrosine kinases. Interference with Bruton's tyrosine kinase, for example, is probably what stops CLL cells from maturing fully, and it's similar interference with other tyrosine kinases that allows them to die slower than they divide, which is why they build up. These premature cells always express particular proteins on their surfaces, including CD5, CD19, and CD23. The CD part stands for cluster of differentiation, because these are common surface proteins which can be used to differentiate between the lymphocytes. And despite CLL cells being B lymphocytes, they express the CD5 protein, which is a lot more common in T lymphocytes. Anyway, these premature leukocytes build up in the bone marrow and eventually spill into the blood, like in CML. Some of these cells then move to the lymphatic system, and although this does include the spleen, the lymph nodes are typically prioritized. This causes swelling of the lymph nodes, or lymphadenopathy. Then eventually, B cells in these nodes will accumulate into distinct masses, or lymphomas, which is why mature CLL is sometimes called small lymphocytic lymphoma. Further progression might take the form of a Richter transformation, where those small, pretty harmless lymphomas collect into sizable masses that damage the body. And because B cells normally work in the immune system, the reduced or adverse functioning of CLL cells might result in autoimmune hemolytic anemia, where the cells attack the body's own red blood cells and kill them off, or hypogammaglobulinemia, where the cells don't produce enough gamma globulins. Symptoms of both CML and CLL include fatigue because of the anemia, easier bleeding because of the thrombocytopenia, and more frequent infection because of the leukopenia. In CML, the hepatosplenomegaly often causes a feeling of abdominal fullness, while the lymphadenopathy of CLL often causes mild but localized pain in the lymph nodes. The diagnosis of CML and CLL usually starts with a blood smear, which shows a lot of premature leukocytes. In CML, there are an increased number of granulocytes and monocytes, and in CLL, there are often smudge cells in the blood smear, which are immature B cells that have broken during the smear. For a conclusive diagnosis, genetic testing can be done to look for the Philadelphia chromosome in CML and to look for chromosomal defects in CLL. Treatment for CML always includes biological therapy, with a tyrosine kinase inhibitor aimed at stopping cell division caused by the BCR-ABL protein. This is less effective for CLL, though, since there's no specific target.
Okay. Let's look at Khan's Academy then.
So now we're going to talk about chronic leukemias. And chronic leukemias come from these cells over here. And just like we did with the acute leukemias, we can split up the chronic leukemias into chronic lymphoid leukemias and chronic myeloid leukemias. And we're actually going to start off by talking about the chronic lymphoid leukemias. We're going to start off the chronic lymphoid leukemia, which is usually just abbreviated CLL. So even though the name doesn't tell you this, CLL is a B cell leukemia. So it comes from B cell. So CLL develops from this cell over here. So I'm just going to circle that. And you can see from this diagram that the CLL cell is sandwiched in between the B lymphoblast and the B lymphocyte. So it kind of exists in this fuzzy area, this gray zone in between the immature cell and the mature cell. And because of that, it has certain characteristics that are more similar to the immature cell, and it has other characteristics that make it more similar to the mature cell. So for example, in terms of the appearance, how the CLL cell looks, it actually looks pretty similar to a mature B cell. So if you were to look at a CLL cell, it looks pretty much the same as a mature B cell. Now, something that you couldn't tell just by looking at the cell is that a CLL cell is actually not as structurally strong as a mature B cell. So it's weaker, it's more fragile. And if you took, for example, a drop of blood from a patient who has CLL, and you wanted to look at that drop of blood underneath a microscope, you would then place that drop of blood onto a microscope slide, and you'd do some preparations, and then you'd stick it underneath the microscope. Well, that whole process of putting the blood cells onto the slide causes the fragile CLL cells to rupture. That's how fragile they are. They'll rupture. And those ruptured CLL cells are called smudge cells. And it's pretty cool because if you didn't know that the patient has CLL leukemia, just by taking a look at a drop of their blood, if you were to see smudge cells, that would kind of hint you in the direction of a CLL diagnosis. Okay, so that's the appearance of these cells. Well, what about where these cells go to, where they live? Well, a normal B cell, a normal healthy mature B cell, after it's released from the bone marrow into the blood, it will travel to 3 organs. It will go to the lymph node, the liver, and the spleen. And it'll go to these 3 organs, it'll hang out over there and mature a little bit more, and it'll wait for pathogens like bacteria and viruses to show up. And when they do, the B cells will activate and they'll attack the pathogens. That's the job of the B cells, right? So it turns out that in this regard, our CLL cells are also mature enough to home to these same sites. So the CLL cells also go to the lymph node, liver, and spleen after they're released from the bone marrow. Now, let's think about that for a second. In CLL, we have a leukemia, cancer of the lymphoid cells. If all of those lymphoid cells are going to these 3 organs, what's going to happen to the organs? They're going to get bigger, right? And you see that most significantly with the lymph nodes, where after the CLL cells will go to the lymph node, they'll cause a generalized, meaning throughout the body, lymphadenopathy. So it'll cause a generalized enlargement of the lymph nodes throughout the body. Okay, and that has a special name. Why it has a special name, I don't know, but it has a special name. So if a lymph node is enlarged in a patient who has CLL, you can assume that that lymph node is enlarged because it's filled with CLL cells, and that lymph node will be called a small lymphocytic lymphoma. lymphoma. And oma means mass, and lymph refers to the fact that these are lymphoid cells. So it's talking about a small mass of lymphoid or small mass of CLL cells. Okay. And this brings us to a really important point. After these CLL cells travel to the lymph node and they start to take up more space inside there, these cells can then acquire additional mutations that cause them to grow more quickly, more rapidly, and more out of control, and mutations that make these cells stickier for one another. And the result of that is that these cells then form a genuine, a true mass. And that is referred to as a diffuse B cell lymphoma. And the process by which this occurs is called a Richter transformation. So in a patient who has CLL, you may see generalized enlargement of the lymph nodes throughout the body. And after some time, you may see that one lymph node in particular starts getting very big. And that usually signifies that inside that lymph node, there's been a transformation to a diffuse B-cell lymphoma. Okay, so now let's move on to the function of these CLL cells. Are they more mature or more immature in terms of their function? Well, what's the function of normal B cells? Well, usually one of the most important functions of a B cell is to make antibodies, right? Well, in regards to making antibodies, these CLL cells, they fall short. They don't do a very good job at all. And because of that, in patients who have CLL, you see a decrease in the number of antibodies in the blood. So you see a hypo meaning too few, gamma globin. You may have heard of immunoglobulin or gamma globulin being different words used to refer to antibodies. Anemia, meaning in the blood. So hypogammaglobulinemia, meaning too few antibodies in the blood. And that's because the CLL cells do a very poor job of making good antibodies. But that doesn't mean these cells don't try. In fact, they try pretty hard. They actually try to make antibodies. But unfortunately, when they do make antibodies, they do such a bad job that instead of the antibodies attacking bacteria and viruses and parasites, the antibodies start attacking our own cells. Specifically, they start attacking our red blood cells, causing them to rupture and die. And that's referred to as auto means self, immune. So an immune response that is attacking our own body, hemolytic anemia. Okay, so we see a hemolytic anemia or a destructive anemia, red blood cells being destroyed because of an immune response attack.
Wait a minute. You have increased B cell, but you have hypogammaglobulinemia. Why though? Why do you have less antibodies?
They don't do a very good job to make most function of these CLL cells. Are they more mature or more immature in terms of their function? Well, what's the function of normal B cells? Well, usually one of the most important functions of a B cell is to make antibodies, right? Well, in regards to making antibodies, these CLL cells, they fall short. They don't do a very good job at all. And because of that, in patients who have CLL, you see a decrease in the number of antibodies in the blood. So you see a hypo meaning too few, gamma globin. You may have heard of immunoglobulin or gamma globulin being different words used to refer to antibodies. Anemia, meaning in the blood. So hypogammaglobulinemia, meaning too few antibodies in the blood. And that's because the CLL cells do a very poor job of making good antibodies. But that doesn't mean these cells don't try. In fact, they try pretty hard. They actually try to make antibodies. But unfortunately, when they do make antibodies, they do such a bad job that instead of the antibodies attacking bacteria and viruses and parasites, the antibodies start attacking our own cells. Specifically, they start attacking our red blood cells, causing them to rupture and die. And that's referred to as auto means self, immune. So an immune response that is attacking our own body, hemolytic anemia. Okay, so we see a hemolytic anemia or a destructive anemia, red blood cells being destroyed because of an immune response attacking our own red blood cells. Now, that's pretty much CLL in a nutshell. And there's another type of chronic lymphoid leukemia that develops from a B cell, and it's called a hairy cell leukemia. And there are other chronic lymphoid leukemias that develop from T cells. Specifically, there's adult T cell leukemia, and there's mycosis fungoides. Okay? And I'm not going to go into much depth about them, but it's always good to know that they do exist. But CLL, when it comes to chronic lymphoid leukemia, CLL really is where the money is at in terms of what you need to know.
Okay. Acute leukemia.
So now we can talk about the different types of acute leukemias. And remember that acute leukemias come from these cells. So the most immature types of blood cells that you can possibly have. And we can split up the acute leukemias into ones that come from myeloid cells, so these cells, so the acute myeloid leukemias, or the leukemias that come from lymphoid cells, so the acute lymphoid leukemias. And we're going to start off by talking about the acute lymphoid leukemias. So I took the big diagram and I shrunk it down and I stuck it into the corner because, to be completely honest, nobody memorizes this diagram by just looking at it 1 or 2 times. You have to keep looking at it over and over again in order for it to stick inside your mind. So if at any point you're like, what cell is she talking about? Just look up at this diagram to help you reorient yourself. So I said that we were going to start off talking about these guys. So the acute lymphoblastic leukemias. That's often abbreviated ALL, so we don't have to write it all out again. So one of the things that I really loved about learning the different leukemias was that the name of the leukemia told you a lot of the information that you needed to know about it. So the word leukemia tells you that you're dealing with a cancer of the blood cells. Well, what type of blood cells? So this is a lymphoblastic leukemia, so we're dealing with lymphoblasts or immature lymphocytes, immature B and T cells. And just how immature are those cells? So if this is an acute leukemia, we're dealing with the most immature cells that you could possibly have. And really, that's the majority of the information that you need to know about this disease. A couple of other important things is, number one, ALL is the most common cancer in kids. So unfortunately, it affects the little ones the most. And it's also associated with Down syndrome. And you may know that Down syndrome is a genetic syndrome where you end up with 3 copies of chromosome 21. And in a normal cell, you only have 2 copies of chromosome 21, but in Down syndrome, you end up with an extra copy. So you end up with 3 in total, and that's called trisomy 21. Well, it turns out that chromosome 21 has this gene on it, and that gene makes a protein that can damage DNA. So the idea is, among other ideas, that because you have an extra gene, you end up with more damage to your DNA, and that increases your risk of getting ALL. So let's say that you have a patient, a really young patient, who's showing signs and symptoms of leukemia. So you go ahead and you get a bone marrow aspiration from him. And if the patient has ALL, you'd expect that when you looked at the aspirate underneath the microscope, you'd see lots of lymphoblasts, because ALL, after all, is just a cancer of lymphoblasts, right? But what do I mean by you'd see a lot of lymphoblasts? Because lymphoblasts look like all of the other immature blood cells. They look exactly the same. And it's not like they're carrying around a sign saying, hey, I'm a lymphoblast, right? Or are they? Well, they kind of are. Because remember, we said that all lymphoblasts have this protein inside their nucleus called TDT. And only the lymphoblasts have this. So none of the other blood cells have it, and not even the immature lymphocytes have it. So it kind of is like a sign that they're carrying around saying, hey, I'm a lymphoblast. So if the cells in the aspirate have TDT inside their nucleus, then you can go ahead and diagnose the patient with ALL. So moving on, since there are two different types of lymphoblasts, you'd think that there would be two different types of ALL. And there are two different types of ALL. The first one is called B cell ALL, and the second type is called a T cell ALL. And we're first going to talk about the B cell ALL, so that's this guy over here. And going back to our patient that we did the bone marrow aspiration on, we said that in his aspirate, there were lots of lymphoblasts. But how do we tell if that's a T lymphoblast or a B lymphoblast? So there are lots of markers that only B lymphoblasts will have, and there are other markers that only T lymphoblasts will have. So certainly you could use those markers to tell them apart. But there's another really nifty feature of B cell ALLs that you could use to tell them apart. And that is that B cell ALLs are associated with translocations, so chromosome translocations. So we know that there are lots of different leukemias that have translocations associated with them, right? But a B cell ALL has two very specific translocations associated with it. The first is a T for translocation, T1221 translocation. And all that means is that chromosome 12 and chromosome 21 each have a segment that's shifted onto the other chromosome. And the second type is a T922 translocation. And the first and the T1221 is usually found in kids who have B cell ALL, and the T922 is usually found in adults who have B cell ALL. So these translocations are really helpful, or super helpful. They help us diagnose the disease, and secondly, they help us determine the prognosis of the disease. And I say that because it turns out that the T1221 translocation is associated with a better prognosis. And that's because the leukemia cells that have this translocation inside them, the cells themselves are more responsive to treatment, to chemotherapy. And that's for a whole bunch of scientific reasons. But the way I like to think of it is that 12 and 21 are mirror images of each other. So I like to imagine that there's a mirror in between them. And this is my really poor attempt at drawing a pistol, a gun, and the gun is shooting chemotherapy at the mirror. So that leads to this explosion that kills lots of cells around it. And I know it's a really silly way of thinking of it, but for some reason I haven't been able to forget that 1221 means better response to therapy. And sometimes a bad analogy is more memorable than a good analogy. Okay, so that's B cell ALL. Now the other type of acute lymphoblastic leukemia is a T cell ALL. So now we're talking about this guy over here. And I want to start by asking you, when the bone marrow releases T cells into the circulation, into the blood, where do the T cells go? Well, usually they go right into the thymus. And they go there so that they can develop a little bit more. So in T cell ALL, you have lots of T lymphoblasts in the blood. And they can also go to the thymus. And if they do, your thymus will get bigger. And it'll feel like there's a mass inside your thymus. And that's a problem because if your thymus is growing larger, it can compress the structures around it. So it can compress the airway, and it can compress the esophagus. And that'll lead to a whole slew of symptoms on its own. So you can get a thymic mass. And the other thing that's important is that T cell ALLs are most often seen in teenagers. And something that might help you remember these three things is remembering the letter T. So T cell ALLs associated with thymic mass and found in teenagers. Okay, so those are acute lymphoblastic leukemias. Now let's move on to our acute myeloid leukemias. So that means in this diagram, we're looking at these guys over here. You have the acute, those are acute lymphoblastic leukemias. Now let's move on to our acute myeloid leukemias. So that means in this diagram, we're looking at these guys over here. You have the acute myeloid leukemias. Myeloid leukemias. And because there are many types of myeloid cells, you can have several different types of acute myeloid leukemias. And then acute myeloid leukemia is abbreviated AML. So for example, you could have an acute myeloid leukemia developing from a myeloblast, so this cell over here. And that would be called an acute myeloblastic leukemia. You could also have an AML that develops from a monoblast, and that would give you an acute monoblastic leukemia. And in the same way, you could have an AML developing from a megakaryoblast, and that would give you an acute megakaryoblast leukemia. And you could actually get a leukemia, an acute myeloid leukemia developing from an erythroblast, but that's so extremely rare that you won't really hear people talk about it. It doesn't really happen in the real world, but it's good to know that it's possible theoretically, right? So those are all of the different types of acute leukemias. Now we're ready to talk about the chronic leukemias.
I want to know about what group of patients present with what kind of leukemia. The diagnosis here.
So your next patient just walked in, and his name is Joe. And he's here because he hasn't been feeling so well. He tells you that for the past few weeks, he's been feeling really tired, so just not like his normal self. And he thinks that he's lost some weight. So you check up on that and you find out that he's actually lost a significant amount of weight. And he looks a lot thinner and weaker than he usually does. So you talk to him, you calm him down, and then you start to examine him. And right away, you notice that his skin looks a lot paler than it usually does. So this is what Joe normally looks like, but today he looks a little bit more like this. And you notice that he has bruises all throughout his body. And when you ask him about the bruises, he actually can't remember getting them. He doesn't remember ever getting hurt. And when you check his temperature, you see that he has a fever. So as you're finishing your exam, he tells you, well, I've been feeling this pain throughout my body, and it feels like the pain is inside my bones and inside my joints. So he's also been having some bone pain. So if you're worried about Joe, then your instincts are on point because there's definitely something serious going on over here. But at this point, you probably don't know what that is. Is this infection? Is it cancer? Is it some rare, crazy disease? It's really hard to tell at this stage. So you might start off by ordering some basic studies, some basic labs, right? And one of the labs that you might order would be a CBC. And a CBC stands for complete blood count. And it's a really cheap and easy test to get, but it tells you a lot of information. So this is the typical information that you get from a CBC. So it tells you the number of red blood cells that you have. It gives you your hemoglobin and your hematocrit values, which are indirect ways of measuring how many red blood cells you have. It'll give you a platelet count and it'll give you a white blood cell count. And these are the normal values just for reference. So hint, hint, Joe has leukemia, but we don't know that yet because we're still working him up. So CBC shows us that he has a decrease in his red blood cell count, and that's called anemia. And he also has a decrease in his hemoglobin and hematocrit, and that's just from the decrease in the red blood cell numbers. And he also has a decrease in his platelet count, and that's called thrombocytopenia. Okay. And finally, he has a decrease in his white blood cell count, and that's called leukemia. Actually, in leukemia, you could also see an increase in white blood cell count. And that's because in leukemia, eventually, the leukemia cells run out of space to grow inside the bone marrow. And when that happens, they leak into the blood, and you start to see them in the blood. Okay? And these leukemia cells are usually immature white blood cells, just because most leukemias are white blood cell leukemias. So the person who's counting all of these cells, who's giving us our CBC values, sees these immature white blood cells, sees these leukemia cells, and he or she counts them as white blood cells. And that's why you have an increase in the white blood cell count. But if you looked more closely at the blood, you'd actually see that the number of healthy, mature white blood cells is always decreased. So this CBC is really concerning. It tells us that our patient Joe has a shortage in the number of all of his blood cells. And that actually accounts for most of the symptoms that he came in with. So you should feel like you're heading in the right direction towards finding out what's wrong with him. Okay. And you might wonder, well, what's causing the shortage in blood cells? Is the bone marrow not making enough blood cells? Or is the bone marrow making enough blood cells, but then the cells are being destroyed after they're released into the blood? And really the only way to answer that question is with a bone marrow aspiration. So if this is a bone over here, you could stick a needle inside the bone, inside this cavity in the center of the bone, which is where the bone marrow is, right? And with this needle, you could then draw out some fluid. And then you could look at that underneath a microscope. So in leukemia, what would you expect this fluid, the bone marrow aspirate, to look like? Well, I'm going to give you a couple of seconds to think about that while I draw the answer. So I've drawn this diagram like 1,000 times already, but I just wanted to remind you that in leukemia, your immature blood cells, your crazy leukemia cells, take over the entire bone marrow, so much so that there's no space left inside the bone marrow. So if you took a sample of this bone marrow, it would show you two things. So the first thing that it would show you is lots and lots of cells. So an increase in the number of cells compared to what you normally expect to see. And so we call that a hypercellular bone marrow, okay? And hyper just means a lot, and cellular means cells. So hypercellular bone marrow means a bone marrow with lots of cells in it. And that's exactly what you get with leukemia. And the second thing that you'd expect to see is lots of immature blood cells, right? Which are called blast cells. And in normal bone marrow, do you see immature blood cells? Well, sure, because the mature blood cells have to come from somewhere, right? They come from the immature blood cells. But in normal bone marrow, only 2 to 3% of all of the cells are immature. Only 2 to 3%. But in leukemia, the number of immature cells is greater than 2 to 3%. But it's not enough to say that it's just greater than 2 to 3%. We need to quantify how much greater it is. So in leukemia, more than 20% of all of the cells in the bone marrow are immature blood cells or blast cells. So if we do a bone marrow aspiration and we see that more than 20% of all of the cells that we're looking at are immature cells or blast cells, then we know definitively that the patient has leukemia. So you figured out what's wrong with your patient, you diagnosed him with leukemia, but it's not enough to stop there because you have to figure out what type of leukemia he has. And that's important for being able to tell him what his prognosis is and for being able to determine what his treatment should be. So the next step would be to classify the leukemia. And this can be done in one of two ways. The first way seems the most intuitive to me, and that is to look at the leukemia cell, okay, to characterize the leukemia cell. So I want to take you back to this diagram, which we used to talk about the development of the different types of blood cells. And you can see the mature blood cells down here. You could tell these cells apart in a snap. They have such distinctive appearances. But these blood cells up here, the immature blood cells, these cells pretty much look exactly the same. So you can't tell them apart just by looking at them. And remember that leukemia cells are immature blood cells, okay? So they look like these guys. So going back to our leukemia cell that we're trying to characterize, looking at the cell isn't going to be enough. We're going to need to do more to try to figure out what type of cell it is. So in order to find out what type of cell this is, we look at what molecules the cell has on both on the outside and on the inside. Because different blood cells express different molecules, different unique molecules that allow us to identify them. So I want to give you an example. So for example, lymphoblasts, right, which are immature lymphocytes, so immature B and T cells, have this protein inside their nuclei. And that protein is called TDT. And only the lymphoblasts have this protein. So the mature lymphocytes don't have this protein and all the other types of blood cells don't have this protein. So if Joe's leukemia cell comes back positive for TDT, we know that his leukemia originated from a lymphoblast. Another famous example is of a myeloblast. And remember that these are the immature blood cells that make the neutrophils, eosinophils, and basophils. This is a myeloblast. And a myeloblast has this protein, this enzyme in its cytoplasm that's called myeloperoxidase. And myeloperoxidase, you often see abbreviated as MPO. And we have a stain or a paint that binds to myeloperoxidase. So we can take the leukemia cells from our bone marrow aspiration, right? And we can flood them in this stain, in this paint. And if the cells take up the stain, if they become colored with the stain, we know that the patient's leukemia developed from a myeloblast. So that's the first way that you can classify your leukemia. The second way is by looking for a chromosome translocation. Remember, chromosome translocation looks something like this. And we said that a lot of leukemias are associated with chromosome translocation. So you can look to see if your leukemia cell has a particular chromosome translocation that's associated with a particular type of leukemia, and that can help you classify the type of leukemia. And so this is how you diagnose leukemia.
Okay. Let's look at up to date, see if they have nice article on leukemia. You don't have an overview. So we need to learn about each leukemia one by one. In adults, acute lymphoblastic leukemia, acute myeloid leukemia, acute lymphoblastic leukemia in children and adolescents. Treatment. Outcome. Clinical manifestations. Acute myeloid leukemia. Acute lymphoblastic leukemia. Okay, let's try acute myeloid leukemia first. Acute myeloid leukemia, AML, also known as acute myelogenous leukemia, consists of a group of relatively well-defined hematopoietic neoplasms involving precursor cells committed to the myeloid line of cellular development, those giving rise to granulocytic, monocytic, erythroid, or megakaryocytic elements. AML is characterized by a clonal proliferation of myeloid precursors with a reduced capacity to differentiate into more mature cellular elements. As a result, there is an accumulation of leukemic blasts or immature forms in the bone marrow, peripheral blood, and occasionally in other tissues, with a variable reduction in the production of normal red blood cells, platelets, and mature granulocytes. The increased production of malignant cells, along with a reduction in these mature elements, results in a variety of systemic consequences, including anemia, bleeding, and an increased risk of infection. The presenting signs and symptoms and diagnosis of AML will be reviewed in this topic. Epidemiology. Okay, this is what I want to know. AML is the most common acute leukemia in adults. Acute myeloid leukemia is the most common acute leukemia in adults and accounts for approximately 80% of cases in this age group. In contrast, AML accounts for less than 10% of acute leukemias in children less than 10 years of age. So AML is mostly in adults. In the United States and Europe, the incidence is reported as 3 to 5 cases per 100,000 population. In adults, the median age at diagnosis is approximately 65 years. The incidence increases with age and approximately 2 to 20 cases per 100,000 population for those under or over 65 years. So it's an older age group kind of leukemia. Median age and diagnosis is 65. So in those under 65 is 2 in 100,000, but those over 65 is 20 cases per 100,000. The male-female ratio is approximately 5 to 3, so more common in males. This incidence is similar among persons of different races. In one study, non-Hispanic whites has the highest incidence, 4 cases per 100,000 population, while Hispanics, whites, blacks, and Asian Pacific Islanders have a slightly lower incidence. Non-Hispanic whites, 3, not very big difference. AML has been associated with environmental factors, exposure to chemicals, radiation, tobacco, chemotherapy, and genetic abnormalities. For example, trisomy 21, Fanconi anemia, Bloom syndrome, familial mutations, for example. In some patients, evolution to AML is preceded by evidence of clonal hematopoiesis manifest as myelodysplastic syndrome, myeloproliferative neoplasms, paroxysmal nocturnal hemoglobinuria, and aplastic anemia. Details regarding these associations and the pathogenesis of AML are presented separately. So you can transform from any of these to AML. Clinical presentations. Patients with AML generally present with symptoms related to complications of pancytopenia, anemia, neutropenia, and thrombocytopenia, including weakness and easy fatigability, infections and variable severity, and or hemorrhagic findings such as gingival bleeding, ecchymosis, epistaxis, or menorrhagia. Combinations of these symptoms are common. Fatigue is present in the majority of patients and often precedes the diagnosis of a number of months. Pallor and weakness are common and attributed to the anemia. Bone pain is infrequent in adults with AML, although some individuals describe sternal discomfort or tenderness, occasionally with aching in the long bones. This may be especially severe in lower extremities due to expansion of the medullary cavity by the leukemic process. It is generally difficult to precisely date the onset of AML, at least in part because individuals have different symptomatic threshold for choosing to seek medical attention. It is likely that most patients have had more subtle evidence of bone marrow involvement for weeks or perhaps months before diagnosis. This can sometimes make the distinction between de novo leukemia and leukemia associated with prior hematologic disorders such as myelodysplastic syndrome somewhat arbitrary. As an example, it is not uncommon for a patient to present with AML and to find evidence of a possible undiagnosed and asymptomatic myelodysplastic syndrome from blood counts obtained months to years earlier. Okay. So AML usually present in those in adults, especially in adults more than 65 years old. Okay. And not AML, this is CML. AML or CML? AML. I was reading about AML, wasn't I? AML. Acute myeloid leukemia. Acute myeloid leukemia. Overview of the clinical presentation and diagnosis of acute lymphoblastic leukemia or lymphoma in children. I've read this one. So I've gone through acute myeloid leukemia. I'm going through acute lymphoblastic leukemia. Acute lymphoblastic leukemia, ALL, or lymphoblastic lymphoma, LBL, is the most common childhood malignancy. Leukemia and lymphoma are overlapping clinical presentations of the same disease. Diagnosis and classification do not distinguish between these entities. Diagnosis and classification do not distinguish between these entities, and they should be referred to collectively as ALL or LBL. ALL, LBL comprises of B lineage, T lineage, and uncommon variants. In other words, NK lineage, early T progenitor, ALL. The clinical presentation, evaluation, diagnosis are reviewed here. Risk group stratification and treatment. Are discussed separately. What is risk group stratification? Oh, it's still in children and adolescents. I thought it would be in adults as well. Alright, epidemiology, ALL or LBL, acute lymphoblastic leukemia or lymphoblastic lymphoma, right? Accounts for approximately 1/4 of all childhood malignancy and is the most common form of cancer in children. ALL or LBL is 5 times more common in children than acute myeloid leukemia. Because acute myeloid leukemia is more common in adults more than 65 years old. The distribution of ALL, LBL categories is B cell lineage, 85%, and T cell lineage, 10 to 15%, and NK lineage, less than 1%. Approximately 2,500 to 3,500 cases of ALL, LBL are diagnosed in children each year in the United States, with an incidence of approximately 3.4 cases per 100,000. The incidence varies worldwide, but this may be influenced in part by diagnostic and reporting differences. The incidence of ALL, LBL is higher in Hispanics, whites, more common among boys than girls. The incidence of childhood leukemia appears to be increasing, as demonstrated by the following studies. However, the increased incidence of ALL or LBL may also reflect more accurate reporting. A study from Nordic countries reported that the incidence of childhood ALL, LBL remains stable at 3.3 cases per 100,000 in children less than 15 years old from 1983 to 2002, after an increase in incidence between 1975 and 1983. Risk factors. The vast majority of cases of ALL, LBL have no known cause, but an increased incidence has been associated with certain environmental or genetic risk factors. Large studies have reported an increased incidence of ALL, LBL in association with advanced paternal age and maternal fetal loss, hazard ratios less than 1.1 for either. A Scandinavian case control study of more than 1,900 children with ALL, LBL reported that increased birth weight was associated with increased risk of ALL, LBL, odds ratio of 1.26, not very high. However, children with leukemia did not weigh more at birth than their siblings. These are insignificant conclusions then. In most cases, childhood ALL, LBL is not considered to be a familial disease. However, a Scandinavian study, which is much higher risk. Certain genetic syndromes, for example, Down syndrome, neurofibromatosis type 1, Bloom syndrome, ataxia telangiectasia, are associated with an increased risk of ALL, LBL. Rare germline mutations predispose to the development of ALL, LBL, and large-scale genomic studies have noted that polymorphic variants are associated with an increased risk of leukemia. Presentation. The most common presenting findings associated with ALL, LBL are non-specific and may be difficult to distinguish from ordinary self-limited diseases of childhood. A meta-analysis that included more than 3,000 children from 33 studies reported that more than half of children with childhood leukemia had at least one of the following 5 features on presentation: palpable liver, palpable spleen, pallor, fever, or bruising. Palpable liver, palpable spleen. So hepatosplenomegaly, pallor, fever, and bruising. 6% of children with more than half, okay, so it's quite a majority. 6% of children were asymptomatic at the time of diagnosis. Evaluation of these clinical findings is right below. Hepatosplenomegaly, lymphadenopathy, fever, hematologic abnormalities, musculoskeletal pain, 43%. All right. Now we know ALL is most common in children. What about the chronic leukemias? Chronic myeloid leukemias first. So we should look at AML first. We're gonna see CML first. The epidemiology. Okay. Chronic myeloid leukemia, also known as chronic myelocytic, chronic myelogenous, or chronic granulocytic leukemia, is a myeloproliferative neoplasm characterized by the dysregulated production of uncontrolled proliferation of mature and maturing granulocytes with fairly normal differentiation. CML is associated with the fusion of two genes, BCR on chromosome 22 and ABL on chromosome 9, resulting in a BCR-ABL fusion gene. This abnormal fusion typically results from reciprocal translocation between chromosomes 9 and 22 that gives rise to the abnormal chromosome 22 called the Philadelphia chromosome. It is this derivative chromosome 22 that harbors the BCR-ABL1 fusion gene. This BCR-ABL1 fusion gene results in the formation of a unique gene product, BCR-ABL1 fusion protein. This protein product includes an enzymatic domain from the normal ABL1 with tyrosine kinase catalytic activity, but relative to ABL1, whose kinase activity is tightly regulated, the kinase activity of BCR-ABL1 is elevated and constitutive due to fusion with a protein of BCR. It is this dysregulated tyrosine kinase that is implicated in the pathogenesis of CML. The clinical hallmark of CML is the uncontrolled production of mature and maturing granulocytes, predominantly neutrophils, but also basophils and eosinophils. In the absence of treatment, CML has a triphasic or biphasic clinical course as it progresses from a chronic phase to an accelerated phase and on to a terminal blast crisis. Sometimes it goes from chronic phase directly to blast crisis, particularly when the blast phase is lymphoid. What do you mean the blast phase is lymphoid when you're talking about chronic myeloid leukemia? The clinical manifestations and diagnosis of CML will be reviewed here. Okay, this is what I want to know. Epidemiology. Who present with CML? CML accounts for approximately 15 to 20% of leukemias in adults. It has an annual incidence of 1 to 2 cases per 100,000 with a slight male predominance. The median age at presentation is approximately 50 years for patients enrolled on clinical studies. But the actual median age from cancer registry data may be 10 years older. Exposure to ionizing radiation is the only known risk factor. So CML is another leukemia in adults, not in children, because the median age is 50 years, I guess. While there is no known familial depositions to CML, rare families in which multiple members develop myeloproliferative neoplasms, including CML, have been described. Studies of these families suggest the presence of an autosomal dominant mutation that may predispose to acquisition of a secondary somatic mutation such as the Philadelphia chromosome translocation or JAK2 mutation. It is unknown whether specific genetic variants predispose persons in the general population to develop CML. However, a genome-wide association study of Korean and European cohorts suggests that persons with genetic variants at two chromosomal loci, 6q25.1 and 17p11.1, may be more likely to develop CML. The prevalence of CML is steadily increasing in the Western world due to the dramatic effect of ABL1 kinase inhibitors on survival. So more people are surviving. Oops. Didn't mean to click that. It is estimated that there will be more than 180,000 patients living with CML in the United States by the year 2050. Clinical manifestation: CML has a triphasic or biphasic clinical cause, a chronic phase, which is present at the time of diagnosis in approximately 85% of patients, an accelerated phase in which neutrophil differentiation becomes progressively impaired and leukocyte counts are more difficult to control with treatment, a blast crisis, a condition resembling acute leukemia in which myeloid or lymphoid blasts proliferate in an uncontrolled manner. The varying definitions of these disease phases are discussed in more detail separately. The clinical findings at diagnosis of CML vary among reported series and also depend on the stage of disease at diagnosis. 20 to 50% of patients are asymptomatic, with the disease first being suspected from routine blood tests. Among symptomatic patients, systemic symptoms such as fatigue, malaise, weight loss, excessive sweating, abdominal fullness, and bleeding episodes due to platelet dysfunction are common. Abdominal pain and discomfort may include left upper quadrant pain, sometimes referred to the left shoulder, and early satiety due to enlarged spleen with or without perisplenitis and or splenic infarction. Tenderness over the lower sternum due to an expanding bone marrow is sometimes seen. Acute gouty arthritis may also present at this time due to overproduction of uric acid. Other frequent findings include splenomegaly, present in 48 and 76% in 2 series, anemia 45 and 62%, white blood cell count above 100,000, 52 and 72%, and platelet count above this much, 15 and 34%. Involvement of extramedullary tissues such as lymph nodes, skin, and soft tissues is generally limited to patients with blast crisis. So usually it's white blood cells and platelets are raised and anemia is present. Okay, so AML, acute myeloid leukemia, is in adults more than 65, and acute lymphoblastic leukemia is more common in children. And chronic myeloid leukemia is more common in adults. How about CML? CLL. CLL. Chronic lymphocytic leukemia, small lymphocytic. Okay, there's the last one of the 4. So introduction. Chronic lymphocytic leukemia or small lymphocytic lymphoma, CLL, SLL, is a mature B cell neoplasm characterized by a progressive accumulation of monoclonal B lymphocytes. CLL is considered to be identical, i.e. one disease with different manifestations, to the non-Hodgkin's lymphoma, SLL. The malignant cells seen in CLL and SLL have identical pathologic and immunophenotypic features. The term CLL is used when this disease manifests primarily in the blood, whereas the term SLL is used when involvement is primarily nodal. Okay, epidemiology, clinical presentations, pathologic features, and diagnosis and differential diagnosis will be reviewed here. Epidemiology. CLL, SLL is the most common leukemia in adults in Western countries, accounting for approximately 25 to 35% in all leukemias in the United States. So this is another adult leukemia. chronic lymphocytic leukemia. So out of all these, only ALL is common in children then. The disorder is more common in men, with a male to female ratio approximately 1.2 to 1. It is not very much, to 1.7 to 1. The incidence rates among men and women in the United States are approximately 6.75 and 3.65 cases per 100,000 population per year, respectively. In Europe, these incidence rates are 5.87 and 4.01 cases per 100,000 populations per year, respectively. It is estimated that 21,250 new cases of CLL, SLL will be diagnosed in the United States in 2021. Blah, blah, blah. Worldwide, there are approximately 191,000 cases and 61,000 deaths per year attributed to CLL, SLL. Less than 10% of patients present with a non-leukemic picture, having only nodal involvement. This presentation accounts for less than 5%. Okay,